Dear colleagues and friends, welcome to this session, this broadcast on innovations in treating complex PCI, the role of orbital atherectomy. What we're about to do is give you insights on orbital atherectomy, how it works, how you should apply it, and what kind of patients you can treat with it. And then we will also put and add some perspective to how it stands as a therapy in the armamentarium that we have to treat calcified lesions. We just had a very exciting session at TIO focused on calcified lesions with two exciting live cases. Well, believe me, this 1 hour session on orbital atherectomy will definitely be complementary. I am so happy to be joined by two well-respected physicians and experts in the field. We're talking about people who are doing a lot of cases, have a high case volume, and a lot of credibility, both clinically and scientifically. We have Kambis Mashayeki from Heart Center Lahr in Germany. And we also have Dr. Amir Kaki from Ascension St. John's Hospital in Detroit. Maybe without further ado, I would like Amir to start giving an overview of the technology and data on orbital atherectomy. Amir, the floor is yours.
Thank you so much, Nick, for having me, and congratulations to yourself and the organizers. This is a fantastic meeting and really setting the new precedent for how we do these scientific sessions. So I was asked to talk about the device, the mechanism of action, and briefly to clinical data. As you know, my time is limited to 10 minutes, so I'm going to be moving rather quickly. So as we talk to the device has several components, which you could see there. We're going to focus a little bit on the wire with a dedicated slide. You could see the pump, the lubricant, and the actual atherectomy device, and we'll talk about them in detail. This is actually the only device that is approved for severe calcium. From a functional perspective, for those of you that are in high volume labs, or efficiency is really critically important to your day, the ease of setup is very helpful. The prep time is about 2 minutes. And the other thing that I really like about that is that this is very user-friendly, and that you could use this as a single operator without any difficulty. It is 6 French compatible, which is important. And if you look at actually the device has ergonomic advantages in that you could use this as a single operator. You could see where you turn the device on, the button in the middle, and the advancer of the atherectomy here ergonomically is very well designed. It has 2 settings or speeds, low speed and high speed. I've done probably over 400 cases, and very rarely, if at all, will you ever have to use the high speed if you use this device properly. And that adds tremendous safety if you're just sticking to the low speed. The crown is 1.25 millimeters, not to be confused with the burr, because it's 1.25 and the mechanism of action is in orbit, as opposed to the rotoblader. You could treat much bigger vessels than 1.25. There is a brake on the end of the device, which pushes, when you push this down, and this prevents the wire from spinning when you're doing the atherectomy. This is a major advance compared to the first generation wire. This is the Viper wire. It has a flex tip, and this is actually an advancement that allows us now to primary wire these lesions, which historically you would use a workhorse and a microcatheter or a balloon to exchange for your CSI wire or Viper wire. But with the flex tip technology, the wire acts more like a workhorse. The tip is 1 gram force, it's nitinol, and you're able to wire very tight lesions, and this saves you time and efficiency, and it's a very safe wire. So that was a big advancement. The pump, you could see here, it's a very relatively easy pump. Your cath lab staff will like it, the ease of use. It doesn't, obviously, you don't have to come in with big tanks and such. You prime it, and it has a power source, usually to the wall, and saline is used during the procedure. The Viper slide is the only thing I'll say about the Viper slide. It's very effective. You can't do the procedure without it. Keep in mind that there is one of the ingredients is egg yolk phospholipids. So if your patient has an egg allergy, then avoid using the Viper slide and CSI. So keep that in mind. Understanding the mechanism of action. So briefly, as we dive into mechanism of action, I'll show you this video that's illustrative. Let's see if it's going to play. But so basically, it looks like it's not going to play. But basically, it's a 1.25 millimeter crown that orbits, and this is in a 3 millimeter glass tube. And the point of this is to show you in 2 views that the device orbits in a vessel that's much bigger than the size of the crown, proving that a single size can treat almost any vessel, particularly depending on what size or what speed that you're going. And you could see this is a very nice illustration in a glass tube showing the mechanism of action in the sagittal and in a transverse view in a 3 millimeter tube. So atherectomy, it provides differential sanding, and we hear this term a lot. So what does that mean? It means that the device will actually treat the calcified lesions, and as it comes against normal tissue in the vessel, it will not hurt that tissue. Also, it provides pulsatile forces, and it modifies the plaque. So really, when I talk about this to the fellows, we tell them that what we're trying to do here is you're not trying to get luminal gain, although you do get some luminal gain as proven by imaging. We're trying to prep the vessel for the definitive therapy, which is the stent. And you know that you have a good prep when you use atherectomy, because when we take a non-compliant balloon, we could confirm good prep if we could get one-to-one dilatation without a waste in the balloon. So this is an adjunct to really definitive therapy, which is the stent. And a lot of severe calcific cases historically were very hard to do. And you could see our outcomes when you look at 1 month and 3 years at TVR and TLR. Without this vesicle prep, our patients weren't doing very well. So here's the concept of differential sanding, where the orbital device treats the calcium, and it really does not affect the intima and the tissue that is not calcified. So that's a very nice safety feature of the device. So the mechanism of action, you can see here in this cartoon, the differential sanding, modifying not only the plaque that it touches, but also the vessel. And here you could see an example, a very nice OCT image that I think Dr. Van Meeghem will highlight the imaging, but you can see what happens to the deeper plaque, that although the device does not touch, but you could see deeper plaque is affected. And this is why you see significantly improved compliance post-atherectomy in these patients when we treat them with balloon stents. So here's the two approaches. If you compare this, what is the difference between orbital and rotational atherectomy? And to be very honest with you, within my practice, we're 100% orbital atherectomy, and we've been so for probably about going on 5 years. It is worth noting some of the difference, and I'll tell you some of the clinical safety differences in my practice is you will never see an orbital atherectomy device get stuck. You can't say the same of rotaburs getting stuck. We've seen them several times, particularly with the smaller burr. We've seen entrapment. The reason you won't see this with orbital is because the device could work in both directions, both forward and backwards. And if you look at the shape of the device, it is much different than the rotational device. The other thing that's important to know clinically is you don't need to use transvenous pacers when you're doing right coronary arteries or dominant circumflex arteries. And the reason for that is the particulate size is very small, and you don't see the microvascular plugging when you're doing or orbital atherectomy that we've seen historically with rotational atherectomy. So this is, and the other important point is you notice that blood is always going to be able to go for the most part, unless the lesion is super tight and you're doing like a pilot hole. But for the most part, because the mechanism of action, blood will always get to go through this vessel at the time of atherectomy. And we hypothetically, that helps with mitigation of microvascular plugging that you don't see with rotablation. So when you talk about some other options now that we have, more contemporary is lithotripsy, IVL. So IVL is a balloon that's used to modify calcium. It treats intimal and medial calcium. It does not remove the calcium, but it does provide fractures to facilitate balloon dilatation and stenting. The experience is limited. You guys are familiar with the DISRUPT data, and long-term data with IVL is ongoing right now. We do have clinical data with the orbital atherectomy with up to 5-year follow-up, and currently, closing a big randomized control trial that we'll get to. So the clinical goal when we're using these technologies really is to change the compliance of the vessel to facilitate ultimately the stent. And you can see here what happens to this patient before and after atherectomy. This just demonstrates in a cadaveric model what happens to the compliance of the vessel becomes much more pliable, allowing us to deliver our treatment. And you could, sorry, I don't know if you guys could see that. You could see, unfortunately, we went through it too quick. Okay, If you look at, so the mechanism of action in summary, you have the atherectomy providing the differential sanding that we talked about, which actually reduces calcium in the lumen and affects medial calcium to make the vessel more compliant. And these pulsatile forces are hypothesized to affect the deeper calcium to allow us to get a good balloon inflation and ultimately have a good stent without malapposition and full expansion. So that is a mechanism of action. That's a little bit about the device. So what is the clinical evidence that we have to support this utilization? Orbit 2 is a study looking at safety and efficacy. This was a multi-center prospective study that was done in the United States. It was single arm. There was no, at the time, there was no FDA-approved percutaneous treatments for severely calcified lesions to be compared against. This had over 440 patients at almost 50 U.S. sites, and looking at a primary safety endpoint of MACE, which was traditional, and the safe efficacy endpoint being procedural success. And the key inclusion criteria, just in the interest of time, is the vessel size had to be 2.5 to 4 millimeters in size. The calcium had to be less than 40 millimeters, and you had to have evidence of severe calcium defined by either IVUS, showing greater than 270 degrees of calcium, arc of calcium, or using the MENS score, where you had severe calcium just based on the fluoroscopy on both sides of the vessel. The patients that were included are patients who had stents in that vessel, recent myocardial infarction, renal failure patients, or patients with reduced ejection fraction less than 25%. If you look at the lesion and vessel characteristics, these were very tight lesions with core lab adjudication. The mean pre-procedure stenosis was 85%, and the mean minimal lumen diameter was only 0.5 millimeters. So you're looking at very tight lesions, heavily calcified. And if you look at the final procedure minimal lumen diameter, it went from 0.5 to 3, almost 3.0 at 2.9. So the procedure results were good. If you look at the angiographic complications, I think it's very important to look at this critically, particularly when looking at safety. If you look at the cumulative complication rate, they were actually acceptable. You could look at, compared to standard PCI, you could see it was it wasn't much higher. You could see abrupt closure being 1.8, and type C aft dissections were at 3.4. These are, keeping in mind, very severe calcific lesions, and you can see that relatively safe when compared to angioplasty in this high-risk population. What about the other safety endpoints? Looking at 30-day MACE, it exceeded the performance goal, and 89.6% of the patients had freedom of MACE at 30 days. So we were very pleased with the safety given this high-risk cohort of patients. Procedural success was the primary endpoint defined by stent delivery, and you could see 97.7, almost 98% of the patients, we were able to successfully deliver a stent. So this was met that endpoint. If you look at TLR rates, so beyond the index procedure, how did these patients do when they had orbital atherectomy compared to just standard DES, looking at historical DS trials? Actually, these patients did better. And if you look at 1 year, 2 years, and still sustained after 3 years, that these patients did better. We're looking at TVR. These are the institutions, from coast to coast that were participated in the trial. Right now, there's a retrospective study going on. But more importantly, I think what we're looking forward to is actually the randomized clinical trial, which is the Eclipse trial, which is currently enrolling in the United States and close to completion, almost 2,000 patients. This will be one of the largest patients looking at calcified lesions, randomizing patients to orbital atherectomy strategy versus conventional angioplasty strategy, looking at contemporary generation drug-coated stents, with endpoints being MSA based on imaging with OCT and a sub-study, and procedural success. Stent delivery historically has been the endpoint that we've looked at for success. So this study is currently enrolling, and I think we're getting close to completion. So we applaud all of the operators and the institutions help gather this very important data. So with that, Nick, I'll conclude. Thank you. And if you have any questions, we can discuss them when it's appropriate.
Thank you very much, my friend. Thank you very much. So we do have some poll questions. So why don't we start with the first poll question? for the audience. Can we bring that question on? Okay, so the question is, how familiar are you with the orbital atherectomy system? Several options: very familiar, somewhat familiar, acquainted, no knowledge. If I can comment for the European perspective, there's only be a limited release. More and more centers are being trained as we speak. More and more countries are being started. But still, there is a lot of work to be done. Amir mentioned that in his practice, it has been the go-to device for calcified lesions for over 5 years. That is quite impressive, and you know, that kind of level of expertise is just not available in Europe at this point in time. But while we are awaiting the results of the poll, maybe one question for you, Amir. So you basically abandoned ROTA from your practice, or in your practice, but you've never encountered failures to cross the lesion with this orbital device, or is there anything that you can advise when you are encountering a difficult lesion to cross?
Yeah, so that's a good question. So I've never been not been successful in a case where I'm able to get the Viper wire down. So the challenge with these platforms is you have to get the Viper wire down. And same thing if you were doing rotablator. So and really in very bad chronic total occlusions or recalcitrant lesions that don't yield, if you could get the Viper wire down either through your microcatheter in these cases, then I could promise you without exception that you'll be able to be successful as defined by stent delivery. The limitation obviously is you have to use this wire, Nick. And so we've all had these cases where you could cross a CTO, but then you don't have the luxury of actually getting the Viper wire down. And in those cases, we haven't been successful. But when we've gotten the wire down, we've been successful.
Yeah. So Camus, obviously you are a master in complex PCI. You also have experience with orbital atherectomy. This issue of wire bias that we know from ROTA, that doesn't exist, obviously, but is it like a real issue, or is this something that, is it an illusion, or is this a real issue with rotational atherectomy?
Well, probably it might be even an advantage, right? That you don't have the wire bias. And well, it depends on the eccentricity of calcification. So if you have eccentric calcification, sometimes the big burr with a wire bias, just the burr pass without touching, in some cases, the calcium. So therefore, some people who are doing a lot of ROTA go with a smaller burr to reduce the wire bias, right? To stay in the inner curve and then make a shortcut of the calcified nodule, and then go in a second attempt with a higher burr, which means 2 burrs. So that I don't see this issue at the moment with rotational atherectomy with the CSI system. Another point regarding the uncrossable lesion, if I may say something to that, is that sometimes we have in CTO scenarios that we can cross with the wire, but not with the microcatheter. And even the low profile balloon are not crossing, which are the absolutely non-uncrossable lesion. And there the Viper wire has a certain advantage, because if you're able to get the microcatheter towards your uncrossable lesion just in intra-plaque position, the lumbricity of the Viper wire is very elegant for crossing through the lesion. And then sometimes you might be even successful on uncrossable lesion to cross with the orbital device, even if it's not the front cutting device. And for sure, this might be the strength of ROTA, but the wire behaves sometimes a little bit better than the ROTA wire in these scenarios. So therefore, it's a very interesting device for that as well.
I think it's an important comment. I think this Viper wire technology really is attractive, also in quite challenging lesions to wire overall. I think if maybe we can put that in a question for Amir. How often do you wire a lesion with a more dedicated wire and you exchange for the Viper wire versus directly wiring it with the Viper wire?
Yeah, so that's a great question, Nick. So prior to the ViperWire Flex system, I used to 100% of the cases I would use, my workhorse wire and a microcatheter or balloon and change out. Since it was released here in the States a few years ago, we're actually using this as a primary wire. There's very few cases where it doesn't cross and you have to go to your traditional workhorse wires. But to answer your question, it has been a game changer and allows us now to primary wire where historically we did not. I just want to make one comment regarding Dr. Cambis's assertion about these non-crossable lesions. I think in these very non-crossable lesions, people historically have used a small rotaburr. And if you look at the cases in rotaburr where you have entrapment, it's that subset of patients. And people used to think that that was one of the advantages of rota because it is front cutting. I think it's actually one of the disadvantages because sometimes you'll get across this lesion and you can't get the burr back. So in these particular cases, I really do think that this is an advantage that is really understated of having orbital atherectomy. If you could get the ViperWire Flex down, then I think this is actually a safer approach than potentially getting burr entrapment.
Yeah, I think your comments on the bidirectional treatment are very well taken, and it is definitely my go-to device when I have osteo lesions. So I would feel a little bit uncomfortable targeting osteo lesions with rotational atherectomy for the reasons that you just mentioned, because you only have unidirectional forward treatment. So you may force your way through the osteo lesion. Exactly. But that doesn't guarantee you that you'll be able to come back. And the orbital technology allows you to enter the lesion, but also come back. And by coming back, you even are providing therapy and modifying the calcium. So I think that is an important aspect of orbital atherectomy, and also a question, an answer to the question from the audience. There is this question you will get all the time, and let's park that question for later in this session. Why would you use orbital atherectomy over rotational or IVL? But we'll discuss that at a later stage. But maybe it's 4:30, so it's time maybe to now zoom in on patient selection and lesion selection. And Cambis has some slides on that.
Yeah, thanks, Nicholas. So yeah, let's go through it. First of all, once you start or once you have a case with calcified lesions, I think it's very important to just sit down and look at the lesion, then really make yourself a plan about that, which means first you have to evaluate your calcification level. So how much calcium do you have? And this means that first of all, you evaluate clinical predictors. It's clear if you have somebody, for example, with on dialysis, that there might be a higher burden of calcification. And then you have your angiogram to assess calcium. You have CT planning, pre-assessment in some cases. And then as well, you have your IVUS or OCT imaging. And that gives you a strategy plan for assess the lesion and to modify the plaque. And once you start with orbital atherectomy, you should reconsider imaging after you've done the orbital atherectomy before deploying a stent. What you might want to see actually is some fractures of calcium. I think we will see afterwards some cases from Nicholas regarding the plaque modification on IVUS and OCT. So this is the way you should go once you do your first you do your first cases on orbital atherectomy. Sure, I mean there is a clear rationale to identify calcium. I think based on the sake of time, I think we should go directly in the patient selection criteria. If you're interested to start with this technology, which is kind of, let's say, new in Europe, it's only some, it's only quite a year, I think, since we started with CE market here, and we used the device. So for your first cases, I think you should have a clear angiographical visualization on both sides to see that you have really circular calcification, or at least on IVUS 270-degree or more arc of calcification. So don't start with the eccentricity on calcium, and the lesion length should not be too long when you start with the first procedures, and then also you should look for reference diameter between 2.5 and 4.0, and one important thing is don't go for too much angulations and tortuosities, because you should really let's say you should go to the borders of what the device can do and what you're able to do with the device, and this takes a little bit time, and you may learn from your mistakes as well. And in very tortuous anatomies, it might end up in a dissection, and which is with all the atherectomy devices what is happening, and this you should keep in mind. And then you should stop with doing the rotational the orbital atherectomy. So whenever you see a dissection, then retrieve your device. This is also very important during the procedure. And a very good thing is that you can also work with guide extension catheters, and yeah, for sure, for the first cases, don't go for a case with let's say hemodynamic support. Sure, if you have more and more experience, what you're going to treat is longer lesions, more diffuse calcification. And there is something what I realized is might be a little bit positive, or something a good thing about this technology is that we see a little bit less slow flow. So even on long calcified lesions, it's in a way atraumatic during the procedure. I see a little bit less of itchy changes, less slow flow problems during the procedure, and this is very interesting, and this makes me feel comfortable, especially in high-risk patients with low ejection fraction. So yeah, here's a clear angiogram where you see, I mean, I don't have to go through that exactly, but you see what I mean is when you have calcification, check it in REO view, also in LAU view, and that you have circular calcium, and then you're ready to go. But this is quite often already seen from Jeremy Hines in 1995, but we see an increase of calcified lesions general worldwide. One important thing is that whenever you see a certain kind of calcium or shadow in the angiogram, it probably, and if you are an image user, and that you should do that, in my opinion, if you are going to treat heavily calcified lesions or also calcified lesions, it makes sense for plaque preparation to go with imaging. That's clear. So, and I think there are 2 studies running now, and this will be big, large endpoint studies. We will show, and they will clarify the question whenever in complex PCI imaging can play a role in regarding hard clinical endpoints. But what you see here is that, especially if you don't see too much calcium in this case, you see circular calcification, superficial calcification on the IVUS, and this is the opposite of what you see in a CT. You see often an overestimation of adventitial calcification, but here you have a relatively thin but circular calcium. It's probably a little bit more fibrocalcific, but it can lead, if you don't crack it, to recoil. And this is very important to understand, that when you place a 3.5 stent there, that there might be a recoil if you did not crack it, right, probably. And well, I mean, OCT has even better and more beautiful images. Sometimes for calcium assessment, it's not so the easiest way to discriminate, but I think as more we do it, the more and more easier it is. There's also new technologies with artificial intelligence, with the new machine of Abbott. So it's giving us, let's say, the answer of what we are seeing, even if you're not so routine with OCT images. Yeah, what you should do before the procedure, there is a clear SCT recommendation. I think you can go almost always radial. That it's also important, especially if you think about not the people like in Netherlands, which are 2 meters, but about 1.60 meters, ladies where you really want to avoid in a way a femoral puncture, and you still can go with 6 French radial, and it's a very smart because you can treat the 4.0, 4.5 left main distal calcified bifurcation, and as well with the same device you can also go distally in the circ, for example, in a 2.5 vessel and ablate there as well. So it's in an economic point of view also interesting to work with orbital atherectomy in this case. And you can have also godliner support for sure. And well, the pacemaker, it is a consideration. I personally, I'm not a pacemaker user anymore in atherectomy devices. So then we already talked about crossing the lesion. It's clear we have this wiper wire. There are 2 opportunities, let's say. It's even if you go with the wiper wire by itself, what can I tell you here? The thing is, if you have tortuosity, calcification, angulation, do not over-rotate it. Because in very tight lesion, it might be even that the wire can be has a lot of friction. If you over-rotate a wire which has a lot of friction, then you might even have a wire break. It's a very rare scenario, but just to keep in mind, this can happen. So if the wire does not advance, do not rotate it or spin it. So this is important information. Just go through it slightly, or, and this is the best way to exchange the wires in general, take a workhorse wire, a microcatheter, and exchange it over the microcatheter. So now treating severe calcium, and it is a worldwide disease, as you can see, and the incidence is going up. Well, there are some studies saying 6 to 20%. There are some stent studies going up 30, 35% of the lesions are calcified lesions. And we all know the predictor of calcium, which are for sure the kidney disease, diabetes, and hyperlipoproteinemia, long-term state CSE inhibitors. So, and also pre-cabbage, which is a predictor for fibrocalcified lesion, very fibrotic stuff as well, and for sure older age. So why is calcium a problem? In general, what we can see is that our outcome in patients with calcified lesion is not so good as when we treat patients without calcified lesions. So, the long-term result, if you put a drug-eluting stent in a healthy segment of the vessel, what we saw multiple times before the FFR era, where some people thought that a 30% stenosis has to be treated with drug-eluting stents, and they were happy because after 5 years it even looked perfectly. Vice versa, you can have a very tight lesion on a very calcified scenario, and you put a drug-eluting stent, you have a perfect primary outcome, but long-term or even a short-term outcome can end up in a restenosis, like in the case today by myself, done 6 weeks before, even if I was and everything was perfect. So we know, and we have to also talk to the patient, that there is a higher risk for TLR, but not even DLR, but especially also regarding MACE and hard clinical endpoints, what we see here in a retrospective analysis of AQT and Horizon AMI. So this has to be taken into account when we treat patients with multivessel disease and calcified lesion versus other, let's say, revascularization strategies. Nevertheless, why is this so important? Because those are the patients where we really have to focus on very high quality on PCI. Yeah, and this is also an analysis over 70 drug-eluting stents trials showing the same, that was 6,300 patients, higher MACE rate, higher death rate, and 3 years outcome in coronary calcification. So it's a predictor. Calcium is a predictor for worse outcomes. So what are the challenges? What is imaging telling us, and why imaging is important? As I said before, we will focus a little bit later on, but just to give you three main messages. What you can see with imaging is, first of all, do you have an incomplete stent deposition? Normally, you should not have that if you're a routine operator, but it can happen in proximal LADs, and you might be surprised sometimes, right? What you also see is stent under expansion. So MSA is a very important tool as well to measure how is the MSA. And this stent under expansion is often because of thick, really thick, non-fractured calcium parts. So once the stent is there, you can only go anymore with high pressure balloon or a shock wave, something like that, if you see an image like in the mid part. And what we also can see is an end H dissection, which is a predictor for even a stent occlusion, and also for peri-interventional myocardial infarction. So let's say the primary one, in the middle one, the stent under expansion should be avoided based on let's say a proper plaque modification upfront. So probably we'll see something about the MSA, but there is a relation between MSA and TVR. It's going a little bit more into the IVUS and imaging endpoints, but I think we should, if to reduce the worse outcomes, we should do a better stent optimization based on imaging. So now, let's say you decided now to start, and there are good programs with CSI, and you will get very routine, let's say, people who are doing already followed over 1,000 procedures, multiple thousand procedures, which will help you to get through the first procedures. Was the same when I did my first procedures, and actually, if you are used to do rotational atherectomy, it's not a big deal, right? You will see the wiper wire. You will be very surprised how good it is, and then you have your. We already discussed this. You have your device here, but it's very interesting to see the comparison between rotor and orbital. But Amir already talked about that. There is less wires, as you can see here. And then you have the wiper wire management, wire position. What's important to see is that you have here on this part, the radiopaque part here. This is the transition point where you have in a way the break. So this should be in a good distal vessel position. And yeah, and then you can just go with your device down. And one important thing that you should keep in mind is that you should go slow. And this is probably a little bit the boring part of the procedure. If you're a rotor guy and you did a lot of rotablations, you really try to go fast, and sometimes it might end up in a burn treatment. Here you go slow. You have to take your time, which means, and this is also why you have to go slow, is beautiful explained in the green and the blue parts. So when you have a transverse speed of 1 millimeter per second, you will hit more calcium parts in the plaque modification, and this is more efficient. When you just go fast, you will just hit 10 millimeter per second. You will have an insufficient plaque modification. And so therefore, you should go forward with the device very slowly. You take your time, you stop, you can go backwards and forwards, but very, very slow. And then you have a better plaque modification, definitely. And yeah, so this is the key points. I think we can go also through it later on in the discussion, but one important thing is that you should stop at 25 seconds of treatment. That's also important, and the treatment should not exceed more than 5 minutes. But saying that, I will give you some personal experience that even if you go higher regarding the time, normally you don't end up in some slow or no reflow. It's very, very rare. When there is no reflow, you might have a huge some dissection, something was going wrong in a way, then you have to keep the wire in place and go directly for imaging and stenting. Okay, so I think now it's time. The time is passing, and I give over to Nicholas for his cases regarding imaging. We're happy to look forward to Nicholas. To you.
Thank you, Canvas. Thank you. That was a very practical presentation. I think you presented quite a lot of tips and tricks. I think one of the important features of Orbital that also came in your presentation, and Amir showed it too, is this: what is an orbital movement, right? This really explains why you only need one size of orbit and you would need multiple sizes of a rota. And so a rota will just move like this, straight in a straight line, and there can be wire bias, so it can be eccentric in the lesion and then go forward. Whereas this orbital thing is rotating. And so if you go slow, the radius will become larger. And that is why you can treat also larger vessels with a 1.25 orbital atherectomy device, so the Diamondback. And I think that is, you have to, if you're not familiar with the concept, you have to take a little pause and try to understand what's happening. And then you also accept the fact that you have to go slow, because if you go fast, you will not reach that radius. So I think this is also what Amir mentioned in his first talk. You don't need the higher speeds. You just need 80,000 RPMs, but a slow movement, as you mentioned, Canvas. Amir, am I saying anything strange here?
No, absolutely. I agree with you. I think the need for using the high speed is going to be very low. You guys will encounter as your experience grows. And exactly what Nick said, just by the mechanism of action allows us to treat bigger vessels than, you would consider, because we're focused on rotaburs being size 1-to-1. This is a totally different application, as I think Nick elegantly discussed.
Yeah, and Camus, you mentioned also the lesion complexity. When you're a novel user, try first with some more approachable lesions. Get the discipline right, and then you will ramp up lesion complexity as you get more experience. I think that makes total sense, and I think that is the recipe for success.
It's clever, right? I mean, if you start skiing, you don't go down to the, double diamonds, right? And at the end, the patient is paying the price. So therefore, you should really start tranquilo and just take your time, and then you can increase your level for sure.
Yeah. So another question on the imaging: do you need to be an imaging nerd, or can you get away with some practical imaging knowledge? Canvas,
well,
what do you think?
In the past, it was not so easy to get, let's say, education on that. But let's say in the last 2-3 years, the whole internet is full of it. So, people are reading books before they go to bed, but if you're interventional cardiology and you want to learn, you can also watch video clips. And it takes your time to understand the images, right? And this takes time. I remember I was flying to Japan to understand what they're doing in the early 2010s around, because I wanted to understand extra plug, intra plug, and how plug modification works. What I see often actually is that people are doing imaging, but they don't see any consequence out of it. And then I understand that they don't understand what the image is telling to them. So they're just doing it by fake. So this doesn't make sense. Then you can save the device. But now I think the overall level is increasing, and we have own imaging specialists. So especially when we look at the States, they have more money for that as well. But it's very good to see. I think also you in Rotterdam, you have your own imaging stuff. So I think it's a great thing to have them on board, and that really, I think, really can make outcomes better, right?
Yeah. Well, but suffice to say that that you do need a basic knowledge of invasive imaging, but it makes sense to have also some imaging experts in your center, like in Rotterdam too. I'm not a super expert. I know imaging, but there are people who are a little bit more granular than I am when they are looking at these images. We did a poll when we started. The poll question was, "What is your experience with orbital atherectomy?" Can we see the results briefly?
Wow.
Yeah, that's
so
what I
only
thought.
18% is very familiar. So this is why it's also good to reiterate on the device principles. And I think from an interventional cardiologist point of view, the technology makes sense, and so you will only get more attracted by it the more you get exposed to it. There was also another poll question that we didn't bring up yet, and that is how likely is your hospital to adopt orbital atherectomy? Is it very likely? Is it definite? Is it somewhat likely, or is it unsure? And I think this would bring us to the final segment of our session. And I have a couple of slides that tries to bring orbital atherectomy a little bit in perspective of calcified lesions and what we have in our treatment armamentarium. And so basically, this is what Gambus was mentioning also. Right? So you have invasive imaging is crucial when you are treating patients with calcified lesions, but you do have to have some level of understanding. And on top, you see the IVUS images. Below, you see the OCT images of the same lesions. So, and you see that it looks a little bit different, right? So with calcium by IVUS is very dense, is hyper echogenic, and there are reverberations. There is this echo shadowing behind the calcium. With at OCT, you see these signal low entities. There is a low signal. It's very different. I mean, light cannot cross the calcium, but at the borders are sharply delineated. And that sometimes both technologies are complementary. And this is very nicely illustrated in the middle portion here. You see an IVUS image and you see a density, and you might think, okay, this is almost 270 degrees of calcium, but you see by OCT that it is not calcium. It is very sharply delineated. This is an accumulation of macrophages. This is so lipids and lipids. This is not calcium. And here you see a calcium nodule that is also clearly visible by OCT. But on the right-hand side, you might have the impression that that is a thrombus. But then when you would do the IVUS, you would see the reverberations, the echogenic shadowing, and this obviously cannot be thrombus. So that's why invasive imaging and a minimal knowledge of invasive imaging does make sense, and sometimes both imaging techniques can be complementary. So we have these dedicated tools for calcific coronary artery disease, and let's just start focusing on the middle, where we have rotational atherectomy, then orbital atherectomy, and intravascular lithotripsy. And basically, these are three fundamentally different principles. We know that rotational atherectomy has several sizes. There is this sizing thing, but also once you start to use a burr that is larger than 1.5 millimeters, you will need a 7 French system. Rotawire is also necessary, and there is unidirectional ablation operations. And you can adjust the RPMs. With orbital atherectomy, basically, as Amir alluded to, you only use the 80,000, or you predominantly will use the 80,000, but you have the luxury of bidirectional treatment. And I think this is important, it is 6 French compatible. And what you do is not differential cutting, but differential sanding. And Amir already illustrated that this polishing effect of the sanding, but also the fact that it predominantly will treat calcium and it will leave healthy tissue untouched, is an interesting aspect and a nice to have related to orbital atherectomy. And then we have also intravascular lithotripsy. It's a pulsatile mechanical energy. You inflate a balloon to 4 atmospheres, and then you have these emitters that send out high tones. This is 014 wire compatible, and basically is a different concept. I think that some, if not the 3 technologies, can be complementary as well. So here is an example of how rotational atherectomy affected a calcium nodule. And what you see is that there are some superficial tears in the node created by the rotational atherectomy. And this is what orbital does. There's also a nodule of calcium, But here, the calcium is completely dysmorphic. It has become dysmorphic by the orbital movements of the device. And sometimes you really can completely abolish the nodule. So we are very, very charmed by the results on nodular calcium when we are using orbital atherectomy. As a matter of fact, these days, nodular calciums are indications specifically to use orbital atherectomy. The same thing for osteal lesions, also a prime indication for orbital atherectomy. With lithotripsy, you typically have these deep cracks in the calcium, also in the media, that extend into the media. As a matter of fact, Amir also showed that you may find these kind of effects also with orbital atherectomy. So orbital atherectomy may not only be restricted to the superficial calcium at the intima, but also create fractures and cracks in the medial calcium. So how would I then use an algorithm in my practice? Well, first of all, you make an angiogram, and then there is a high likelihood that I would proceed with imaging just to get more granular information on the calcium. And then there is the golden tree. You need to know how long is the calcium, how deep is the calcium, and is there a calcium arc of more than 270 degrees. Oftentimes, you can use the 3 different technologies. And now there should be okay, so when you're not able to cross with your imaging catheter, well, basically that is a reason to select orbital or rotational atherectomy. You will not be able to pass with an IVL. At the same time, when the stenosis is less than 80%, but you do have a lot of calcium in terms of an arc of more than 270 degrees, but the lesion length is less than 30 millimeters, and there is also medial calcium, that is when I would prefer an IVL. At the same time, when the lesion is more severe than 80%, and it's a long segment, then I would prefer rotational or orbital atherectomy. At the same time, when it's nodular calcium, or it's osteal, or there is more tortuosity, that would be, for me, a reason to opt for orbital over rotational or IVL therapy. At the same time, I think you have to realize that at the end of your orbital atherectomy or rotational atherectomy, I typically follow up with a non-compliant balloon, 1-to-1 size non-compliant balloon, and then put in my stent, but always try to monitor what I'm doing using invasive imaging during my procedures. With that, I would like to conclude my presentation. Maybe we can briefly show the final results of our poll question. So how likely would your center adopt orbital atherectomy? So very likely 38%, 13% definitely, unsure 25%, so 1 in 4. So I think there still is room for improvement here. I think the community still needs to embrace new technology, but I think the more available orbital atherectomy will become, the higher the likelihood that centers will adopt. But I think it's clear that its ease of use, as Amir mentioned, is unparalleled as compared to rotational atherectomy. So in that regard, I would say, yeah, that the likelihood is quite significant that also Europe will eventually start using orbital atherectomy. Amir, any final comments from you before we close this session? You're muted.
Yeah, sorry, Nick. So a practical point that we didn't mention was actually the dwell time of how much time is the actual technology inside of the patient. And in my practice, we actually, when we use a device, we do 2 runs at about 15 seconds each with a timer with 15-second rest in between the runs. And to be honest with you, in over 95% of the cases, that's more than adequate. So it's very safe, it's very efficient, and it's very effective, and doesn't take a lot of time or pose tremendous risk to your patient, assuming that you have the right patient selection. So I strongly endorse it for your heavily calcified lesions. And really want to thank you and Canvas for having me. A very esteemed panel, and you guys are doing a fantastic job teaching us and leading us in Europe. So it's nice that we have more experience with you than you guys, and at least in one device.
Canvas, anything else from your end?
Oh, no, I think it was a very clear message, especially your talk now, make everything very clear. I think, yeah, it is very important to understand that calcified nodule can be a problem, especially when we go with high pressure without plaque preparation up front. So therefore, this could be a very great indication. And we have seen those fractures and also vibrations and OCT. I think it's probably really the class 1 indication, and where in comparison to other devices where it could be really superior. But this is only a niche. I mean, in general, what I experience, Nicholas, is that it is a safe device when you just want to have a good plaque modification calcium, and for sure, the rest you have to learn how far you can go with tortuosities and subsequential stenosis, and long lesions. But the rest, I think, it's very safe, and I think this is important, really important thing, and it's 6 French compatible. So yeah, it's a good add-on. So I don't want to miss it anymore.
Yeah. With these final comments by Amir and Canvas, I would like to close this session. I think this was very instructive, very practical. I hope the participants also enjoyed the interaction with the panelists. These are not only experts, they're also friends in this field of interventional cardiology. So thank you very much, Canvas. Thank you, my dear friend Amir. And I'll see you hopefully live soon. Stay well.
Thank
Bye.
you.